I particularly welcome all current students to this session. This is particularly for you to show you what we have been up to, or some of us have been up to within the pandemic, to also illustrate that if you weren't fully convinced yet, it's really good to become a bioengineer because your skills are needed, in particular in times of crisis such as this one. Some very quick housekeeping. Please try and keep your microphones off during the talk. Similarly, your video off during the talk. After the talk, there will be plenty of time for questions. You can either ask the questions by raising your hand and then ask the question yourself when I call you to do so, or by just writing in the chat and I read the question to Aldo, hoping that I understand the question so I can communicate it. Quick order, thanks to Kemi who organized all of this and therefore deserves all the credit. We had three very successful talks already, and I'm sure the fourth one will be no less exciting. So it's my very pleasure to introduce Professor Aldo Faisal. Aldo, the stage is all yours.
Thank you very much for this kind invitation. Thank you very much for people who decided to join us. I wanted to talk to you a bit about the work that we're doing in the space of AI and healthcare. That's my research area, and how we have performed a significant pivot towards trying to understand how we can develop methods that can support the global efforts to deal with the COVID pandemic. And I'm facing here two challenges. So the first challenge is that I wasn't aware that we had also external guest listeners, and you're of course very welcome. But this changes slightly the amount of information I can provide, because I would have liked to show you a lot more clinical data from our recent work, but as this is not published data, I decided to not show this data till it is published, because this may be reaching people outside of an academic community of Imperial College, and we need to be a bit more careful about how information comes to the outside, as these are all preliminary results. The second aspect I wanted to highlight is that I wanted to show you a few different approaches we're currently tackling to deal with this challenge. So a lot of this is ongoing work, so I'm going to show you a snapshot of what we have, and then mainly verbally paint you a picture of how we're going to apply that, or how this is going to be applied. Again, this is pending on peer-reviewed academic publication, and as you've, I'm sure, seen also in the news, this is really direly required to not end up in the press with some crazy statement about what researchers at one institution may or may have not found or not. So please forgive me if I'm sometimes appear a bit superficial. I'm very happy to take questions on specific things. I just can't show you the data and everything. Good. So having said that, let's switch now to the presentation, and which I hope will not crash my PowerPoint. And there seems to be a problem. 1 second, and it should be coming online now. I hope you can see this, and I'm switching to the slide deck now. So as David already introduced me, I'm the director of the UKRI Center for Doctoral Training and AI for Healthcare, and I'm a professor at the Departments of Bioengineering and Computing. More recently, I've also become a member of the National Emergency Committee for Critical Care as part of the COVID response, which I joined in March, and I'm also the data science lead for the National Service Evaluation of Critical Care. And I'm going to try to provide you a snapshot of what we're doing in this space. I think the fascinating thing about COVID is that it really transformed in many ways things that may have taken in the space of digital healthcare, so the application of data and algorithms in the support of healthcare, from something that may have taken several years to develop and evolve into something that happened in the matter of weeks, if not days, occasionally. And so as part of this effort, we realized very quickly we need to bring together the data that is being produced overall in the world in terms of healthcare data, epidemiological data, but also data held from companies. So one of the first initiatives that we started in April was to try to see how we can use data to support policy making and decision making. That may be on the big picture, you know, do you go into lockdown, do you open or close things? That's really more in the realm of epidemiologists. But on a more practical term, we can also use data, for example, to make recommendations in terms of planning. How many hospital beds do you need? How big is your intensive care station has to be to support the patients you're getting in? How long are they going to stay there? How likely are they going to survive? So a lot of these questions can be tackled if we have approaches and data to support these. So as part of this effort, in which Imperial have, of course, been very globally prominent, we have started an initiative we call the Global Coronavirus Observatory, or the GCO. And the GCO is an initiative that is led by us in the Faculty of Engineering, but has members of all other faculties across college. So we have Katarina Haug from the Abdul Latif Center, which has been so prominent in epidemiologically from the School of Public Health. We have Mauricio Barahona from the Department of Mathematics and the Faculty of Natural Sciences. And we have Mark Kennedy, who is from the business school. Because what we're really seeing in COVID is that it engages and it affects and impacts all aspects of society. So it's only fitting that we have a research team that looks at this challenge from all aspects that we can cover at Imperial. So the Global Coronavirus Observatory, the GCO, aim is to increase the understanding of COVID-19 and the impact. And so we've been seeking data from private and public sector organizations, for example, hospital trusts, telecommunication companies, health and well-being services, financial services, for example, simply knowing how much people are spending in a shop in person or online is already valuable data to try to understand how things may evolve. Environmental data, how is the air pollution moving on? How does this impact healthcare? And of course, mobility data. So, how many cars are going through a certain region, how many people are taking the tube. So the aim of the Global COVID Observatory is to support academic research in economic and policymaking modeling. And this can be applied for government policymaking globally, but also can provide partner organizations that donate us data from the private industry in help private industry better manage and plan what is coming towards them. So what we want to do with this GCO effort is really explore the micro and macro analytics of the global COVID-19 impact and the connections between questions of healthcare, mobility, compliance with policy decisions, treatments that are available, mobility, economic input. So COVID is a global and a holistic crisis that affects all aspects of society. And so we need to take it from the academic end also as a holistic problem that we want to tackle. And the opportunity that we have is that data science, but also artificial intelligence, so algorithms that help us steer through this data have progressed to a level where we can actually really start delivering impact in this front. And oops. So my personal focus is on artificial intelligence for healthcare. And you may have heard a lot about the opportunities in AI for healthcare. You may have heard, for example, that there are now algorithms that can detect, for example, from a photo of a mobile phone that is taken off a skin patch, whether it is a form of skin cancer or not. And these type of algorithms can now exceed the accuracy of diagnosing skin cancer of trained dermatologists. And in fact, they basically can achieve the performance more or less of what we're seeing if you're taking an actual skin biopsy, so in a probe of the skin itself. So we've seen an incredible rise pre-COVID of AI for healthcare. In the UK, we've had, of course, the Topo review that led to very strong recommendations in that domain. And basically, we're seeing a huge potential in terms of the industrial markets to basically take up AI methods to really deliver cost savings and improvements to healthcare systems on the orders of billions of dollars. And I think what's always important to stress is that the application of AI to healthcare problems is really about ways not to replace doctors, but to unload doctors from a burden. And the challenge that we're seeing is basically that with our rapidly rising elderly populations throughout the industrialized world, we're seeing an increasingly unmet demand for treatment, diagnosis and monitoring of people who are falling ill in some form. And the beauty is that we believe that AI can address this unmet clinical demand. So bringing down the amount of people who have not been properly cared for so far, because there's simply a lack of enough nurses, doctors and carers. And so this can take many different aspects, and I'm going to focus on a specific aspect that you will then understand why it has a direct impact on COVID. So maybe I should give you just a brief, very snapshot idea of what AI is about. AI is really algorithms that can learn from data. And the beauty of these algorithms is that they really realize a completely new form of developing technology. So if you think about engineers, the last 5,000 years of human engineering research, R&D, was based on engineer tinkering, trying to find a solution, working out basic principles, and then working out how to build a better technology. And AI has really turned this on its head. And I should be more precise when I speak about AI, I mean machine learning. And so machine learning is the idea that machines can learn from data how to solve a problem. And people like me are actually more focused in working out ways so that machines can learn better from data and so that they can solve problems instead of solving the problems in itself. But of course, as in many applications of engineering, you need to understand the problem that you're solving to build better learning algorithms. And there are basically two forms of AI algorithms that are relevant in the domain of healthcare. One is what we call supervised learning. So that's the setup where you have an algorithm that receives data, for example, in the example of skin cancer, pictures of skin patches. Some of them may be cancerous, some maybe not. And then you label these skin patches either with data from a biopsy or from the decision of a team of clinical experts. And then the algorithm learns to associate the inputs, i.e. the pictures that you've shown of skin cancer or non-skin cancer skin, and the association whether it is a positive or a negative diagnosis. And we call this supervised learning. And probably all of you have by now heard about the term deep learning. So that's the technology that really powers a lot of these methods in the domain of supervised learning. And really what these methods do is they imitate the ability of humans to perceive information. So we call this perceptual artificial intelligence. So we're learning to imitate perceptual abilities of clinicians, say, for example, here, this gentleman spotting some form of brain lesion, or even, for example, a dentist spotting whether there is some form of corrosion in the tooth going on, or some form of chest listening. So these are all processes that require ingesting information and then basically making a call on that information that you've ingested. And that's, if you have the data, very easy by now to apply to many, many domains of healthcare. And so we've seen across many areas of medical research considerable successes in terms of exceeding the capability of average expert clinicians. So for example, be that for detecting dementia or Alzheimer, predicting suicide risk, predicting, for example, mortality of patients. We've seen many of these approaches that are powered by very large data sets of patients. So the column N tells you that, for example, to predict dementia with 91% accuracy. That's a bit of a different measure. It's called AUC, but you can take it as a percent measure for the purposes of this talk. If you have 76,000 patients and a good number of non-patients, then you can basically train a system to spot onset of dementia. And that's true for many, many areas in medicine now, especially for areas in medicine where you have some form of image understanding that is required. For example, predicting cancer from a CT scan, or from looking at X-rays to determine, for example, if a patient has developed sepsis, has developed COVID-19, and you can see that from a specific feature in the images of chest X-rays. So what we are interested in, however, in our work is less the first aspect of the supervised learning, so the diagnosis. What we're interested in now is really modeling the decision-making and treatment strategies that clinicians have. So that's what we call it, not perceptual artificial intelligence, we call it cognitive artificial intelligence. In cognitive artificial intelligence, it's really about mimicking the processes that clinicians need to do when they plan, when they manage disease, or when they're even adjusting the treatments in response to how the patient responds to that. And so in this domain, what you're really seeing is a setting that you may experience from daily life, where you have some form of set system, that equipment, environment, or a business process that gives you information. For example, if you're a paper-based worker, you can can look at data and then you make a decision, or if you're an operator, you're seeing readings from your machine, and you may choose to change the readings on these machines by taking some form of actions. So the important difference to perceptual AI, that we're not just looking at information and making a single call, diagnosis positive or negative, but we're trying to build a system that continuously adjusts its decisions. Because, for example, we may give a treatment, we may then see how the patient responds to this treatment. Some readings about the patient's state, their blood pressure, temperature may go up and down, and that then can lead us to further adjust the treatment. So the important thing is that cognitive AI, it allows us to really model what's going on after diagnosis. That's really the first step of treatment. But now, once we know what you have, we now need to think about how to manage, plan, and adjust your treatments, the interventions that we're doing in the patients to make them feel better. So this type of artificial intelligence that can model these type of closed loop processes, where your actions or decisions have consequences that then affect the system, and then you need to keep adjusting and interacting with the system, is what we call reinforcement learning. So reinforcement learning algorithms are basically algorithms that learn to interact with an environment. They make a decision, we call that an action, that somehow impacts this environment, which may be a patient. And then we're observing how this environment, i.e. the patient's state, changes. And for example, if the patient survives or is released, cured, then the algorithm collects the reward. And if the patient, for example, dies or deteriorates, then we give the algorithm a negative reward, a penalty. And basically the algorithms learn from these interactions to choose actions and seek actions that in the long term will maximize the reward it obtains. So reinforcement learning is actually nothing terribly new. If you think about this type of interactive systems, for example, a doctor and a patient interacting with each other, you have a human doctor that issues an action, i.e. treatment, onto a patient, and this patient responds to that somehow by their physiology adapting to the intervention. And if the patient is then, for example, cured, we can then give this a positive result. So this is a typical interaction between a carer and a patient. Of course, reinforcement learning also applies to very different settings. That's where it's actually been developed in robotics, for example, where you may have, for example, a robotic welding machine that tries to assemble a car, and the car, so the machine does some form of action in terms of movement of the robot arms and weldings, and then the system, the car, responds to that, and through these continuous interventions, you can basically learn how to assemble a car. Now, the interesting thing that now happens is we're in a setting where basically we are not in a pure machine interaction setting, and we're not in a pure human interaction setting. What's interesting is what happens when we're in a setting where, for example, we have now a system that has learned from interactions with humans how to treat them and how to give them better treatments. And in a second, I will explain why this may be actually a useful and desirable thing to have. And so this is what we're going to focus on. The work that we focus on is what we called the Artificial Intelligent Clinician, or the AI Clinician. And this is joint work with two clinical colleagues of mine at Imperial College NHS Healthcare Trust, Tony Gordon and Matthew Komorowski. And basically the system that we've developed is a system that observes doctors, literally looking over their shoulder more or less, what decisions they make on a patient in intensive care. And in intensive care units, the interesting setting is that you have a lot of data digitally corrected. Effectively, all the relevant readings, readouts of physiological state of the patient, the demographic information, blood test, lab results are all stored digitally and continuously collected. So this technology is very advanced in comparison to other areas of medicine and in hospitals. So we have effectively full digital intensive care units that collect this information. We can then observe what type of decisions doctors made to treat a patient, and we can then observe how this interaction loop evolves. And the idea is, if we just have enough data to learn from these interactions, we may basically build a model of how a patient responds to treatments. And so we can predict, oh, if I do this treatment, a patient should respond to it that way. But also we can build a model of, so to speak, the cognitive processes inside the mind of a clinician, how they take in information about the patient and how they then select what treatment to deliver. So these two components are sufficient to build a reinforcement learning system if only we had enough data. So in the terms of intensive care, we had access to two very large data sets pre-COVID, one of 10,000 patients in a single intensive care unit or intensive care units of one hospital where we had these type of interactions. And then we were given access to a second data set provided by Philips Healthcare, which is one of the major manufacturers of intensive care electronics equipment, where we had access to 3 million patients. And so just to give you a sense of the amount of interaction data that we get, you just imagine you have a patient, you have their full electrocardiogram trace, you have when they breathe out, something about the blood gases, the temperature, the weight, any blood tests, all of this data we have for thousands of patients. And if you take an experienced intensive care clinician who after say 30 years of career retires in their late 60s, they will have seen in their lifetime probably around 15,000 patients. And now we're operating on data sets that not only rival the lifetime experience of a single clinician, but outpace them in terms of amount of experience that these algorithms can draw upon by looking at hundreds of thousands of data points, millions of data points that far exceed anything what a single clinician can learn in their lifetime, even if they're reading papers. So I'm not saying that we've reached the point where we have enough data that we can exceed clinical knowledge at the moment, but the question is, how much data do we need? It's not a question, can we do it at all? And so we've started to build an algorithm in this space to help people survive better in intensive care units. So we focused at the time pre-COVID on sepsis. Sepsis is really one of the biggest killers in intensive care units and hospital in general. With every year roughly 31 million cases globally of sepsis, 19 million cases of sepsis are severe, and over 5 million lives are claimed every year due to sepsis. And to give you a sense of what sepsis is an infection effectively that leads to the collapse of your cardiovascular circulatory system. And the challenge with sepsis is that you can cure it with, it's an infection, you can cure it with antibiotics. But the problem is that most of the time, people's cardiovascular system collapses before the antibiotics can show their effect. So you need to somehow find ways of propping up the cardiovascular system. Now, in COVID, sepsis has become very prominent and important. Of course, we've all heard about the crisis in intensive care units and the stress that COVID-19 puts on patients in intensive care units. But what is perhaps less well known is that effectively all patients that die of COVID die with sepsis of COVID. I mean, it's a large-scale failure of the whole cardiovascular and respiratory system that leads eventually to death, but sepsis is a key component of that death. And so in some ways we were well positioned to try to take some of these algorithms that I'm going to describe you that we've developed for sepsis in an intensive care unit and try to see how we can apply them to work with patients and help them survive sepsis and COVID-19. So the challenge in managing sepsis is that you need to basically work out how to keep the cardiovascular system, the blood flow, pumping and working. And the challenge is that on the one side, you can do that keeping the pressure, the blood pressure up, for example, by putting more fluids into the body. So these classic IV drips that you're seeing, and really filling up the system with more and more liquid. Or on the other side, you can effectively constrict the blood vessels through the delivery of so-called vasopressor drugs that also then help prep up basically the blood pressure and keep the circulation going. And the challenge is that we don't, at the clinical level, really understand how we can basically manage these trade-offs between too much blood pressure, too little blood pressure, how much IV fluids to give, how many of these vasopressors drug to give. And basically, if you're not choosing an optimal trade-off, you can have many complications, either leading to organ failure or pulmonary failures, for example. And they're trade-offs that are very difficult to manage because it's very difficult to pin down this complex state in which the physiology of the human patient is. And so here it is the idea that AI may help you with that, right? So there are clear questions, how much IV fluids to give, when to start the delivery of drugs that constrict the blood vessels, what should be the blood pressure target that maximizes survival, and how should you change all these targets and what you should be doing over time, because the body responds continuously. So we basically developed an AI system that tries to learn how to intervene on these patients. And so the idea is basically, over time, you need to make decisions about, for example, at 9 a.m., you decide that you keep the IV fluids constant on a patient, you monitor the readouts, then you see, okay, this patient's IV fluid level should now be adjusted upwards to help prop up the blood pressure. And then at a later time, you decide, okay, let's do nothing, let's observe further, and then later we may want to reduce, for example, the vasopressor dosage and increase the amount of IV fluids we're giving. So this system basically continuously monitors the state of the patient and then is at the same time working out the best strategy to maximize the survival of the patient. So it's really like having an intensive care clinician watching over a single patient continuously 24/7, day and night, and then making some form of treatment decisions. And of course, during the COVID crisis, we saw not only where did we not have sufficient number of intensive care clinicians to support patients individually. So in a typical intensive care unit, one clinician looks after many patients, but we had to basically draw in non-experienced clinicians from other areas, surgeons, for example, who are then working in the intensive care unit, more or less out of their textbook knowledge of medicine, to try to support the highly overburdened intensive care clinicians. So these type of artificial intelligence systems cannot just basically try to work out from very large amount of data exceeding lifetime experiences of clinician, what are the best actions to do. They can also act as a tool, a sounding board, so to speak, for untrained or new or trainee clinicians, clinicians from other areas to support them in their work. Just to give you a sense a bit of how all of this looks like, or more or less how our AI clinician is thinking about patients. So there are algorithms that allow basically us to visualize these many readouts. There are over 60 different variables that we're monitoring, from blood pressure to temperature to the ECG trace of a patient. And we basically can use this information to structure where patients are in a form of map, and I'm showing you here the map. And basically, for simplification, just to think about how the AI thinks about it, it says that a patient can be in a state, and if you're over time, you may go from one state to another. And so here I've represented each state by a circle. The diameter of the circle basically tells you how many patients in our database have been in this state, and the color of the circle tells you how likely it is that a patient will have died or not. So it's the mortality. So red means you're almost certainly going to die if you're in this state, and 0 means you're very unlikely to die. And I'm plotting here the trajectories of a lady and a gentleman. And here you see a gentleman who entered the intensive care unit and was in a bluish state, and then over time they moved between different states, so that you can see this trajectory of how they were doing. And this patient then unfortunately died eventually in this state. And so the idea is really now that a patient may move from one state to another because simply the disease progresses in some way. And so that's why they're moving from one state to another, or because there's some intervention was done to the patient, and that intervention may increase or decrease the chances of survival by moving them into more desirable states. So I'm plotting here in green, for example, a patient's trajectory who started in a state that was similar to that of the patient who died, but in this case, they moved through an intervention into adjacent states and then moved around and eventually were discharged from the intensive care unit at this point here. So this patient survived. And so basically this is a visualization of how the AI is monitoring how patients are moving between the different states and what type of intervention may push a patient towards a more desirable or a less desirable state. And so, of course, implicitly by doing this modeling, we also have a continuous model that allows us to predict the mortality of patients. And so we can trace for the green patient, the yellow patient, how likely they're going to die as they're moving through time. So let's try to understand a bit better effectively what this AI is solving. And I'm drawing this here more or less on a simplified grid world, a video game-like arrangement, where basically we're saying at some point the patient enters the intensive care unit with sepsis, and you want to steer the patient towards the discharge so they survive 90 days after they've been discharged. They're still alive. That's a success for us if we achieve that. And then you can have patients that end up in a state that leads to their death. So now we need to basically chart a path from the ambulance to the healthy discharge. Now that may seem easy for you because you would say, oh, go up, up, right, right, right. But the challenge is, of course, in sepsis, we don't know what interventions mean up, down, left, right, and we don't have the individual states in which a patient may be in, right? And we also don't know what states are next to each other and what states are far away from each other. And so this is where the AI algorithm basically takes all this data, converts and digests it into these states, into these yellow circles, which correspond to these squares. And then there are actions, interventions that the AI then needs to work out on how to move the patient into the desirable state. So effectively, the AI learns for every possible state what it needs to do. So it works out that if you're in this state, for example, here, you need to go to the right, up, up, and then again to the right. Sorry, to go to the left, up, and then to the right to steer into a health state. Or if you're in this state, top left, that you need to go to the right, and to the right. And so we need to look at this. We need to look at this in a way that allows us to. This is my daughter joining us. That allows us to work out for every possible state how to treat a patient. And so we need to be dynamic responsive because, for example, a patient may have had a heart attack or a severe lung infection. And so certain pathways are now blocked off and you cannot steer the patient through these states anymore. So now you need to find other pathways. And so the AI needs to replan. And so, for example, here the recommendation was if in this states go up, and now the AI needs to work out, oh, we need to first go down to the right and then up again to steer to the health state. So we need to be dynamically responsive. And of course, that's what I meant in the first place when we're talking about a cognitive AI, an AI that thinks along as the patient evolves and learns to adjust that. And so in the past, we've then shown, and then all of this pre-COVID, how, for example, we should dose IV fluids and vasopressors so as to minimize mortality. In the interest of time, I'm not going too much into the details, but I'm plotting here the mortality of patients depending on whether the human doctor and the AI doctor agreed. And when the two agreed, we're slack at 0. When the human doctor decided to give more than what the AI recommended, then the mortality went up. And similarly, similar effect if the human doctor gave less. On the side of the vasopressors, this picture is even more dramatic, just showing how good the AI is at charting an optimal pathway. We can then also try to understand how the AI system made its decision. And for example, we can look at many of the readings, and so these are all these little readings here that are available in the ICU. And we can look at simply of what readings, for example, the clinicians appeared to base their decisions, not from talking to them, interviewing them, but actually simply looking as when they made certain decisions, what were the most important values that predicted their decision. And so what we're finding here is that there are a few values that seem to be important here, just 4 numbers, and many, many other values have very little impact on the clinician's decision. In contrast, the AI agent seems to take into account a lot more numbers and variables with a much higher rating. And this is for the vasopressors thing. Another interesting thing that we found is that on the dosage of IV fluids, we found that AI clinicians also chose a very different ordering of what were the most important variables to pay attention to when making a decision, in contrast to what clinicians were deciding upon. So this led us over the years, including up to and into COVID, to improve our system further, make it smarter, and basically, I will not go into the technical details here of the algorithmic and mathematical develops that we need to develop, but basically we have now a model that effectively takes the data and not just, from the data makes a prediction, it basically reconstructs the patient. So we call that a digital twin. So effectively, we take all the data and we have, so to speak, a copy of the patient in our computer, and that is sufficiently good as a copy that we can then work out, if we do these interventions, how can we help the patient to improve or go better or go worse. And so this is basically now being deployed in a system in St. Mary's Intensive Care Unit here at Imperial College London, where we have interfaces that now communicate with the clinician to basically make them recommendation. Clinicians can also basically play and say, oh, I don't want to follow the AI system's recommendation. This is what I would do. And then the AI can say, okay, if you do this, this and this and this will happen. And then a clinician can use this information and basically observe, are the AI's prediction correct or not? What are the trade-offs that I'm seeing if I make these recommendations? And from this interaction, the clinicians can basically learn to build trust in our AI system to confirm whether they want to follow it or not. So then came COVID, and this led us then to work on the National Service Evaluation for Intensive Care. So here the main strategy was, how do we manage COVID in cases where you have acute respiratory distress, basically where your lungs stop functioning well enough that you're not getting enough oxygen into your system. Now, the interesting thing is here, you may have heard about various data sets and data analysis people have done on intensive care units, but effectively, they're actually rather coarse. They're just looking at, what happened with this patient, what drug was given. What we wanted to look here, because we have this data approaches that allow us to do that, is really read off all the machines that are running in the intensive care unit, get data out of the famous ventilators that keep the blood working, the blood analysis, if they're going on various forms of treatments, and have almost multiple time points per day that tell us how the patient is evolving. So we want to, with that, develop some form of prognostic information about how to set ventilation up and what therapies to give, and provide guidance going forward. And this is led by my colleague Bridge Patel from Imperial College London, and he's at the Royal Brompton and Harefield Trust, and myself here at Imperial. So the first thing that we needed to do, and this is where I just show you, confront you with the reality of that, is how do you get data from intensive care units across the country? So that for that, we needed to set up basically a database where people can then, clinicians can then upload data from their relative intensive care unit. And the important thing is it needs to be secure, safe, and encrypted. We needed to basically arrange that we get data sharing agreements between the trusts, the NHS trust that we've been working with, and Imperial College London. So there's a whole dimension of bureaucracy and paperwork that's of course important, because we want to keep the patient data safe, but we also need to get it together so we can do some form of analysis. So we needed to set up this infrastructure first. So at the moment, we have several major intensive care units across the country inside the system that provides us with this very high resolution data, where people really need to go into the machines and read out the data from the machines and give that to us. So at the moment we have around 686 patients in this databases. There are not a lot compared to the 17,000 that I mentioned before, but these were collected over multiple years. These are basically the data feeds that we set up since the start of the COVID pandemic in March, and basically have now the feeds slowly set up in feeding us with information. Of course, the number of COVID deaths is fortunately going down. So actually, and as tragic and dramatic the situation is, the amount of data that we're getting from within the UK is also going down, simply because we have fewer and fewer patients in intensive care units, and some intensive care units are completely free of COVID patients by now. So what we then basically started to develop is tools that allow us to plot out and work out how these patients are being treated. So for example, the intensive care units, are they put on ventilators? So this is basically this board game I showed you earlier, basically drafted out. I'm showing you non-representative data, again, because this is an open call in an open seminar with attendees from outside of Imperial College. And basically it allows us to map out how different treatment strategies are basically pursued. And the interesting thing, of course, is, what we need to work out is how do differences in treatment strategies, and I show you here this data for different different ways of treatment that we found is, a clinician may treat a patient differently because the patient is doing differently. But also a clinician may treat a patient differently because they simply have a different strategy of treating COVID. And so one of the biggest efforts that we've been basically pursuing is try to understand what are the optimal strategies for treating COVID. So the data sets are too small at the moment for an AI to learn that all on itself. But what we're doing is we're combining the vast background knowledge of people in intensive care units from our background data and combining that with the information that we have for COVID-specific releases. And this allows us then to look at how are individual patients being treated, and we're finding that between different institutions, there are different strategies. Again, unfortunately, I have to basically omit the vast majority of my slides here that actually show actual data. But what I can show you is, for example, that if we can do something called a topic analysis, so that's a machine learning technique that looks at different patients and basically tries to associate what type of treatments they're given and how this leads to the survival. We're finding that there are effectively 4 topics that basically describe different combinations of treatment that were given to these patients. And they stand out because they basically form a common strategy of treatment. They may be because some patients are in very severe situation. So topic 3 is basically really patients where the kidney has failed, the lungs have failed, so they're on so-called ECMO treatment, so that's extracorporeal membrane oxygenation. Effectively, there is a system that puts oxygen into the lungs, into their blood directly without the use of a lung to support them. So these are patients that are very severe, but then we're finding also patient groups where basically they're in a similar state in terms of where they are with COVID, but we're finding different topics of applications. So basic different combinations of treatments that people are using. And we're trying to understand what's going on here. So just to be clear, we're looking here at operational data. We're not running a clinical trial where we're saying, okay, we give this drug and then we see how many more people survive. We're basically just looking at the historical data on a daily basis and then try to work out what strategies of treatments have we seen and how successful are they. So that's what we call a national service evaluation. So that's the first project where we're directly applying the AI clinician in intensive care units from across the country. And now in a second study, we are also trying to apply machine learning to learn to distinguish flu from COVID-19. And that's for the upcoming winter 2020 season, where we're expecting and predicting, of course, this is going to be a regular flu, for which I recommend everyone as a non-clinician to take a flu shot as per government advice. And we want to know, can we help understanding whether you caught the flu or actually if you caught COVID, because the symptoms may look very similar. So here we've partnered with a company, Your.md, that basically runs a global COVID tracker. They have, that's a company that has some form of app they developed that they've put out for people to download, and people are basically tracking their symptoms and also logging in these data sets if they're, for example, tested positive or negative. So in this type of data set, again, this is preliminary data, it's not published yet. We have at the moment 90,000 participants. This was from a few days ago, this data, but I think by now we have over 100,000 participants that have, logged their symptoms. And we know what long-standing health issues they have. We know why they've chosen to report, so we know what information they have. But unlike the hospital data that I showed you before, we're trying to basically look here at self-reports, so people feeding us information. So that information may be biased, it may be incomplete, or it may be plain wrong because people don't understand what they're being asked or what they actually have. For example, they can not distinguish a cough from a sneeze. The interesting thing about this data, however, it's a global data set with very large proportions of people responding in India, for example. That's because this symptom tracker is being promoted by Dettol, the cleaning agent company. In the Philippines, we have very interesting data coming from Nigeria, but also the UK is well represented. So in this data set, we can then basically look for standard demographics, how old are people, and we're seeing an interesting distribution, slightly slant towards the younger people because of course, they tend more likely to engage in app-based delivery of healthcare. And we can look at how the differences in age differ. So, for example, you see that we have a lot older populations in the UK taking this COVID symptom tracker than, for example, younger populations. And then we can actually look into the data that we're finding, and that's effectively representative of data that we have for the countries as a whole. So we're finding, for example, in many countries, concerns around obesity. Of course, the UK being very high here, problems with high blood pressure and asthma, but we're also seeing, how do liver conditions and other conditions affect your health. And so we have a good representative mix of the public health record in these countries that is reported in these online questionnaires. We have a good representation of gender and other information, but key data is that we have also information on patients who tested positive, which have symptoms that may suggest COVID, and tested negative but have symptoms, and patients that tested positive with these conditions. And so basically what we're trying now to work out is, if I present you with a whole list of symptoms, like you have chills, diarrhea, fatigue, and so forth, and I know something, for example, about your demographic background, are you a care worker, are you pregnant, what's your gender, we can then, based on the information that we have about the healthy, the unhealthy, or the positive and negative tested people for COVID, can we try to basically learn an algorithm that allows us to factor in all this information, factor in all the symptoms, and then try to predict whether you're positive or negative for COVID if you've not been tested. And the challenge here, from a machine learning perspective, is that, of course, you have to have probably rather serious symptoms for you to be tested in the first place. But we may have many people who are reporting symptoms that look like COVID, but sort of the symptoms are not strong enough that you have actually been tested for COVID. So we need to apply something that we call domain adaptation. So we need to basically work out from the distribution of healthy to positive and negative tested people with symptoms and demographics, how this would map to people who have not been tested, and basically try to build a predictor out of there. Again, I don't want to show preliminary results, because this may cause people to become suddenly very concerned they may have COVID, or suddenly unconcerned about that they may not have COVID, although they have COVID. But basically, this is the algorithmic challenges that we're now trying to solve. And in terms of the mathematical models, we use here probabilistic models, so Bayesian decision theory, and a method recently developed called optimal transport, that allows us basically to map different domains of application tested people to untested people to work out whether they have the symptoms or not. So to support this effort, we need to look at more data. We need to build a better model of how symptoms and preconditions interact with each other. And for that, we're going back to the UK Biobank. So the UK Biobank is a unique cohort to develop in the UK of 500,000 people, 500,000 to 250 patients, for which we not only know and have access to the primary and secondary healthcare records, so GP records, hospital records if they've been diagnosed with COVID or tested for COVID, but also we know what the daily activity patterns look like. We even have a complete genetic makeup of these people. So we can now start basically analyzing this data set and how patients tested for and against COVID in this data set, and try to relate that to analyses that we have from the symptom tracker to basically build an integrated model that allows us to factor in, genetic preconditions, ethnicity, and other factors, and map between these very, highly scientific type of data and the, so to speak, non-scientific type of data, the self-reports collected off the internet. So that's one of the major challenges that we face in AI for healthcare. How can we combine clinical and non-clinical data so that we can provide public health or digital public health advice? And so basically we're looking at these type of data. I'm going to skip most of these because we're also running out of time. But basically we're trying to integrate very different data sources through the Global COVID Observatory to basically build better predictions of where we can end up. And just to give you a flavor of how things may look like here, we can again find in the biobank data, so where we have the genetic information in high resolution clinical information for 500,000 people, we can find again different topics of diseases that seem to cluster together and that are indicative of death due to COVID versus survival due to COVID. And we're trying to basically understand these and map this into our symptom tracker. So with that, I really want to come to an end of my presentation. So a lot of people have been involved in this research. I'm just the person who's giving the talk, but Shlomi Har has led a lot of the work on the COVID ICU data. Bala has been leading on the URND data set. Mathieu has been also working on the ICU data. He's actually worked in ICU during this time because he's a clinical he's a full-time clinician. Lucien helped also build several of these models. So for our lab, it was really COVID, a way to manage the pandemic in terms of the impact that it has on ourselves, to get engaged in COVID research and support the efforts of clinicians and public health officials by trying to work on that. And that gave us agency. So we really did a major pivot toward COVID, and the lab would have looked very different after COVID than it did before COVID. And so I thank you for your attention, and I'm happy to take questions.
Thanks very much, Aldo. What a very interesting talk. I'm a bit conscious of time because I know that you have to leave soon, so maybe we can go straight to the questions. We have questions from the audience for Aldo. Just please raise your hand or write a question in the chat for Aldo. Maybe, Aldo, I start while we're waiting for the first questions to come in. Oh no, we already have the first question from Claire. There you go. Claire is asking whether there are ethical concerns or legal implications, for example, if a clinician decides not to follow the AI advice path.
Brilliant question, very important question. I think the challenge with any AI system is twofold. Either it's completely ignored because it doesn't work well, and that's actually already the case, not for our system, but for many so-called alert systems that are available in hospitals that are fairly non-intelligent, but they simply detect if, you know, a patient's blood pressure is too low or is too high and some beeping goes off. And these are very often simply ignored. The challenge with AI systems is that people may be in awe of the AI system and so feel that they cannot challenge that decision. And I think here, what we're basically saying at the moment is you need to be critical about this AI system. So it provides an advice, and you can choose to follow that advice or not. But critically, our system also provides an explanation why it makes that advice. And you can basically evaluate whether you think this is a reasonable advice or not.
Thank you, Aldo. Aldo, I was wondering, so with the experience now of basically trying to figure out how to do it while the crisis was ongoing, how much better and in what sense do you think you are prepared for dealing with something similar next time it happens from your perspective?
Very good question. As I said, I think we've seen a radical transformation in the UK, but also in many other countries in terms of the digitization of healthcare and the accessibility of data that basically was opened up. So just to give you a sense of that, when we basically started the AI Clinician project 5 years ago, it was very, very hard and near impossible to get hold of data. Now our challenge with the COVID ICU National Service Evaluation was that we had hospitals who did not have any electronic healthcare records of their patients who wanted to participate. So we needed to basically we needed to create Excel spreadsheets that would allow clinical staff in those intensive care units to basically type in information very efficiently and very quickly so we can get their information. And they wanted us to give that information, but they were still in a paper-based system. So what I'm thinking is, going forward, this would be a lot easier and better to manage.
Thank you, Aldo. Do we have any questions from the audience for Aldo? If not, I'll just ask another question. Ria, go ahead.
Hi, Dr. Faisal. Thank you very much for your talk. You mentioned a little bit the bureaucracies and the paperwork a little bit before. So considering all the meandering that new technologies have to go through until they get fully integrated in healthcare systems, what do you think would be a reasonable time frame to estimate for full commercialization of all these technologies that you described?
I love that question. So I answered that a bit cheekily by showing you 2 slides I've not shown you. So another challenge that we saw basically in March was that we need to develop very quickly new technologies, be it for health services and data access and data provision. So what we did is we teamed up with several regulators. So the MHRA, which is responsible for medical device licensing, so Dunkelman First is the medical directors, the Health Research Authority, the quality commissions, and basically wrote a government briefing on how emergency regulations that are already written into the law allow us to overcome several of the, what we see, regulatory pathways that are rather burdensome. So without going into the details of this picture, at the top you see how, for example, an algorithmic software you want to deploy in the NHS, what type of pathway you need to go in a regular setting. And in the bottom you see how, just by applying existing public health exception or emergency regulations, this entire pipeline is radically simplified. So we have seen, not in the case of the Clinician, simply because the data provision has started very late, but we've seen that in the domain of X-ray image analysis, so the understanding of chest X-rays, whether you have the so-called ground glass patterns on your chest, those pathways have gone through, and we've seen several manufacturers delivering with very early January, February collected chest X-rays from China have delivered for free, by the way, technologies for detecting from X-rays COVID that were available by around May, June. So it can go much, much faster in this public health exemptions. So in terms of, if we wouldn't have COVID, I would have said, earlier this year, I would have said 3 years maybe. Now I think we're being in a very different setting. So things are much faster.
Thank you very much.
Thanks, Aldo. Do you have time for a few more questions, Aldo?
Of course, yeah.
Good, good. There's a question whether corporations are generally willing to provide you with data, and more generally, maybe whether you have advice on how you can motivate people to share data.
That's a very important question. Again, I think we've seen a tremendous transformation in terms of what's happening. So, of course, government needs to know how the pandemic is going, so they can basically more or less get hold of the data if they need to. But what we find as scientists is important is that we can publish and expose the analysis to public scrutiny. And so it's about negotiating with the companies to give up their data, because they can perceive a benefit for the general good, call that corporate social responsibility. Because they can actually gain benefit from having given us that data, because we may have more qualified people looking at data from the aspect of a public health emergency than they may have, say, if you're a bank or a mobile phone operator. And so actually we've seen companies actually very willing. Some companies may want to remain anonymous in terms of whether they've given data to the GCO. Others are very prominently advertising that. So URMD, for example, is featuring the GCO prominently as part of their campaign to get more people to participate in these questionnaires. So in general, yes, what you need to be very careful and aware, of course, is it can be very sensitive data. So you need to provide the right ways of protecting the data, that no one can abuse that data. And even if you're publishing you need to basically analyze it maybe in higher detail. But then when you publish this, you need to aggregate that, say a heat map of the country, not saying, this street in London is doing particularly badly or particularly well. So we've seen actually a lot of interest in that from companies, and we're talking to a lot of companies still ongoing to get more of this data in. So that's Aaron's question.
Yeah. Do you want to pick your next question, or should I pick?
Well, I just go up the line. I have
go ahead.
Martin Boutel. For example, when this gives more artifacts about so quicker.
Yeah, maybe read it out for everyone to know what question you're answering. If you want.
Yeah. So I'm picking Martin Boutel's question, who asked, one of the skills experienced clinicians have is to read through often very noisy and artifactual ICU data. So it's messy data. For example, he says that intensive nursing gives more data artifacts, but also equals quicker, sicker patients. So that's basically a challenge about how do we interpret the data, whether it's good data and something extreme is happening, or is it just messy data, maybe in messy data entry in parts. And so the system as such, learns basically decision strategies of the clinicians. So if we have data from experienced clinicians that sort of ignore or basically seem very ambiguous or very relaxed about certain types of data when they're spotting the patterns in the data, and basically don't overreact or don't react strongly on certain data patterns, then the system would extract that. But perhaps what's more important that we should talk about is that, of course, understanding whether data is noisy or messy in itself is an AI challenge. And I've not spoken about this, but there's a second effort going on in the lab of developing AI for data cleanup. So we can basically deal with this artifactual data. Just to give you an example that we saw, so there is a fixed number of maybe 30 drugs that you can call vasopressors. We found in the big database over 5,000 ways of writing down just the name of the drug that was given. So this just gives you a sense of the challenge that we're finding. And of course, there's always human error and human input problems that we can see. I'll take one more question because then I have to go to a different event, unfortunately. So this is from KD Scully. There's a divide in these systems between policy and a more individual patient level. Do you have any experience or opinion on the effect of the EU MDR medical device regulations that came into effect into May? And what have been the challenge of getting these AI systems through as a medical device? I think that's another great question. We just had actually last week a session with the UK regulators on this. We called that a regulatory hackathon to actually see how the EU regulations play out. Of course, we should think about EU regulations because we're very close to the EMA at the moment. The question is, of course, whether departure for some of these regulatory landscapes may be an actual positive outcome of Brexit, whether we want to pioneer more AI-related regulations. So I think the challenge at the moment that AI systems as medical devices are limited by two things. First of all, at the moment, AI systems, if they're not diagnostic, so they're intervention-based, they can only be recommender systems at the moment. You cannot have fully autonomous treatment decisions. Diagnostic systems are by nature recommender systems. They make a recommendation. But the bigger challenge we're facing is that AI systems, once they've been basically regulatory approved and shipped, cannot continue learning. That's a bit like taking a junior doctor who's just got his GMC board certification and basically freeze his brain, and he can or she can gain no more lifetime experience from interacting with patients. And so that's a hurdle that we're seeing in AI regulation for healthcare throughout the world. And so we've been very actively discussing how we can basically allow AI systems to learn on the job by being also evaluated from other clinicians, by seeing what other clinicians are doing to try to keep them learning, not keep them at the level of when basically their certification has been completed.
Perfect, thanks. And unfortunately, Aldo has to leave us because he's got another meeting. So thanks very much again for taking the time, Aldo, to talk to us. It was very interesting.
Thank you very much.
And thanks for everyone for diving in. And enjoy
all the best. Bye-bye.
Bye-bye.